If you work with children with speech sound disorders, today's episode is for you. I brought my crystal ball, and I brought my crystal ball because I'm going to share with you 10 factors that, according to the research, can negatively impact your outcomes when you're treating children with speech sound disorders. I'm also going to share with you the trick, the three factors that are going to matter most for you to get outcomes despite the existence of these negative factors. So make sure to stay to the end so you can hear the three secrets to success after we go through the 10 factors that can negatively impact your outcomes, even if you're doing everything right. So I brought my crystal ball and we can look at these 10 predictors of a more negative outcome when it comes to your speech therapy treatment. And like I said before, I'm not going to leave you hanging. I'm going to leave you with the three factors that you're going to want to pay attention to, that you're going to want to follow in order to gain success despite the existence of these negative prognostic factors. So I have my crystal ball. Let's dive right in to the 10 factors that can slow your progress when it comes to speech sound disorders. The first factor is attention. So with attention, you can oftentimes have a poor working memory. So the way that's going to play out in therapy is you're going to have a child that's not attending perhaps 100% to what you're doing in therapy. And as a result, you have a lack of self-monitoring. So maybe the child is just going through the treatment target and not attending to the process. For instance, if it's the snake sound, making the snake sound, and they're saying the word really, really quickly, and instead of swap, they're whap to me, please. And they're not even, they're blah, blah, blah. And they're impulsively shouting out the treatment target. So you don't have that attention in which they're paying attention to the production. They're self-monitoring. They're using those metacognitive strategies in which they're seeing, oh, do I have my teeth together? Am I making a long snake sound? And that word swap, or am I just saying whap and immediately saying it like that? So the research does indicate when you have those attentional challenges, that's going to impact the rate of progress that you make. However, what I want to tell you with these kiddos is that they are kiddos that you need to be patient with. Because if you're doing everything right in therapy, and we're going to talk about what I consider those three factors, which means everything's right, then good things are happening. However, because of self-monitoring being something that is difficult for someone with attentional factors, you're going to see that they are going to score poorly on the tests. So every quarter, every 2 months, when you give those single word speech tests and you monitor for progress, you may see a flat line when it comes to progress. And these are kiddos, I write about it in my speech sound disorders textbook. I write about that. These are kiddos that at the end of the school year, you're going to see fireworks. These are children that come in one day and it's like we have this ET moment, and they look at me and they say, "Hi, Miss Kelly." And then there's the ka and there's the L, and then I'm saying the R, and all of these sounds we've been focusing on throughout the entire school year. They all come out overnight. And suddenly, literally, a child who a month earlier had 30 more errors than they did the month later. There was like a fireworks explosion moment in which everything connected. And then suddenly, out of their mouth, it's all generalizing. So that doesn't show out throughout the school year, and then we get this spurt. So the reason I say this happens, because I've been doing this for almost close to 25 years now, is that I've had many kiddos that have attentional challenges, and I've told the parents, stay the course. And I'm going to talk about that course at the very end. And I tell them this is the way things are going to work. At the end of the school year, or maybe even the fall, everything's going to click. But we're going to do things right on our side. But self-monitoring is not your child's strength. Then these are the children where you're giving the speech sound test to them. They're flipping the pages really quickly and saying the word really loudly and just shouting out responses as quickly as they can. These are the kiddos that I'm talking about. And the good news is when you're doing things right, and we're going to talk about that at the very end, you are going to see progress. It's just going to take longer to generalize because of the self-monitoring difficulties. So number two, the second factor that is going to impact your speech sound disorders outcomes, particularly in the beginning stages, is children that have a sensitive temperament. Now, these are children that need to feel safe and secure and have a strong relationship with you before they're going to actively participate. By actively participate, I mean before they're going to speak, perhaps, before they're going to actively get involved in your activities. These are children that first have to feel very comfortable and safe and secure with you. And a lot of that is accomplished through predictability. So I use a lot of strategies from trauma-informed care. All children benefit from that. And for instance, with my SIS activities, it's always the same routine. Okay, the first thing we're going to do is we're going to do that treatment target. Then after the treatment target, we're going to pick that sticker. Then after we pick the sticker, we're going to travel and stick it on. And then after that, we're going to check the checklist. And even though the activity is always going to be changing, the routine does not change. And as a result, they feel very safe and secure with me, and then they're able to focus in on the treatment target. Now, when you're working with children with sensitive temperament, what I want you to do is I want you to err on going too slowly when it comes to fading in the demands, especially in the beginning of therapy. What I want you to do is know what the child's interests are. Before the first session, get that from the parent input form. When you know what the child's interests are, I want you to pick those activities out, and I want you to spend a solid month following the child's lead and giving a responsive approach in which you're using the targets, in which you're modeling the targets for the child, in which you're not requiring the child to talk if the child does not feel comfortable yet. But you're using a responsive approach, which involves a lot of linguistic mapping, in which you're talking about what the child's interested, a lot of recasting, which you're taking what the child says, and then you're recasting back to them. Of course, I would say using complex sentences, so you're going to get those maximal language gains, and you're emphasizing these sounds with the child. So take a responsive approach in the initial stages. Make sure the child feels safe and secure. Then fade in the demands. I always say with these children, what we want to do is we want to throw a strike. We don't want to throw balls that the child's not likely going to hit and respond to and give it back to you. We want to throw those strikes. And how are we going to throw those strikes? We're not going to ask the child to participate unless we're absolutely sure that the child feels ready to participate. Because if you're saying, okay, I want you to say blah, 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 and then the child doesn't say blah, 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 the treatment target, then you have a situation of negative reinforcement in which you're showing them, okay, well, demands go away, or if you don't talk, so then what you do is don't participate, and then all those yucky social and communication demands that make me uncomfortable, they go away. So we don't want to do that in that situation. So number three, the third issue that we're going to see that's going to negatively impact your speech outcomes, particularly in the beginning stages, is the co-occurring language delay. So the way this plays out is many clinicians think that a child that breaks down on multisyllabic words is breaking down because they have apraxia. They have childhood apraxia of speech, and that it's very difficult for them to coordinate the 3 syllables or 3 or 4 syllables. Oftentimes, I find it's children with language delays. Because they have a limited verbal working memory, what they're doing is when they're seeing the word elephant, which is 3 separate syllables that you have to put in order and then express, they're instead reduplicating it, like fa fa fa. It's not childhood apraxia of speech. It's that limited verbal working memory. So they'll be deleting the ends of words. You're going to see more deletions with children with language impairment. Maybe they're deleting even sounds within clusters, and it's because they don't have the verbal working memory to hear this is the first, the middle, the initial sound, to not only hear it, but to store it, put it in order, and then express it. So with these children as well, you're likely to see less gains if there's a language impairment, because that verbal working memory is going to affect their ability to sequence sounds, put them in order, and express them. Now, the way that this is why the paragraph is so effective. This is why I like working at a paragraph level, because in speech therapy, when I have the child do that 100-pound dumbbell, which is I want you to go ahead and take 4 sentences and put 4 sentences in order, then the child's able to say elephant, because here the child is only taking 3 syllables and putting them in order. That's like a 5-pound dumbbell in which I've been working at a paragraph level at 100-pound dumbbell. That's a piece of cake for the child. And I never had to work at that multisyllabic level. So that's why the paragraph is so important if you can get there, if you have a child with language delays. And that's why I'll often break the rules, and that I might have a child producing a paragraph, even if it's not perfectly produced or even produced accurately at an 80% level, because I want to improve the language skills. And that's what the paragraph offers me. Okay. Number 4 is hearing challenges. So many of our children have difficulty hearing high frequency sounds, which are the fricatives and the affricates. For these sounds, which are already difficult to produce, and then you have difficulty perceiving how they're made as well, it's going to probably take longer to produce the fricatives and the affricates. It's already challenging to produce them themselves, but you also have that perception difficulty. You're also more likely to see consonant deletion. I tend to see in the beginning or in the middle of words difficulties, because many of the children are not attending to the beginning sound that have hearing challenges, or they're not attending to the middle sound. That's going to present with its own difficulties if you're working with a child with hearing challenges. Number 5, motor speech disorders. So if the child has child apraxia of speech and difficulty in the motor planning and motor programming and execution of these sounds, that consistency in the motor coordination, you're going to see a slower rate of progress, I've found, even if you're doing everything right. But we're going to talk about that at the end, and we're going to say, however, if you're doing everything right, you're going to see better gains. But I want you to be patient and understanding that we're dealing with some motor programming, motor planning issues, which is going to require more repetition in order to build these stable motor plans and programs. That means the rate of progress is going to happen, but what I found, it does happen at a slower. Number 6, structural abnormalities. So for instance, I have many children that have, like, I call it an open bite from pacifier teeth, where they literally have a circle. Some children, some of my sis member told me today about a child that had bottle rot. They talked about where they're drinking soda or whatever out of a bottle, someone was telling you about, and their teeth are literally have a circle of rotted teeth around. Now, I haven't had the pleasure to work with that, but I have had the pleasure of working with pacifier teeth. And that is going to slow the progress because you have an opening. So the child may have a frontal lisp, which I've dealt with, in which you have open teeth there. So it's going to take a longer time in order to get that, because of the structural difficulties, to get the S behind the teeth. Is it possible? Yes. Does it require a higher level of cueing? Yes. Does it take longer to learn because of the open teeth? Yes. So we're still going to do everything that we do, and we're going to talk about that at the end, that works, and you're still going to get there. And we're going to talk about why you're going to get there, but it's because you're working with the child dynamically. It's because you're altering the cues and making sure the child's at an 80% accuracy level. And maybe you do have to do more cueing, but good things are happening. The motor planning, the motor programming, the foundation is being built because you're practicing at an 80% accuracy level. Number 7, this is the 7th factor where you can say, okay, prognostically, this is going to be difficult. Now, I had the great pleasure this summer of I went to a 2-day workshop with Dr. Edythe Strand, the expert. They've probably heard of her. If you haven't, I'm shocked if you're in this field, but she is such an amazing expert as a clinician and as a researcher in childhood apraxia of speech. And she was talking about how she does have a prognosis when she's evaluating the child of whether or not they're going to really make significant gains in therapy or not. And she said that has to do with stimulability. When she gives them every tool in her toolbox using dynamic temporal tactile cueing, which we're going to talk about in a bit, is the child able to produce the sounds then? And if they are, if the child is stimulable, we use that term, that means the prognosis is better, that they're going to make better gains in therapy than if they're not, when you give them a maximum level of cueing. So low stimulability is another factor that is prognostically predictive of poor outcomes. However, I'm going to talk to you in the end how, despite all of these factors, we're going to stick with this three important factors. We're going to stick with those three important factors to override these negative predictors. Okay? Number 8, the older age of intervention. So oftentimes I begin working with a child when they're 5 or 6 years old, and they've had the W for R, I'm going to just say, like they say, wake for rake, or they have the frontal lisp where they say thun for sun. Now, because the R and the S are so frequent, they're the most frequent sounds in our language, they have, at age 5, 1,000,000 times been producing W for R, or 1,000,000 times they've been producing the frontally lisp TH sound for S. As a result, when I begin working with them at age 5, it takes longer to unlearn this erred motor pattern. And that's why I work on the R's and I work on the frontally lisp S at age 3 preventatively. I incorporate that into my therapy. Is that the speech target? Is it okay with this child's 3 years old and they need to have that R down? The child's 3, we need to have a perfect S? No. But I am constantly planting the seeds, planting accurate motor plans and programs at the age of 3 so that when they're 5 years of age, they're not doing hard W for R, or they're not lisping the S. And I asked my elementary age speech language pathologist colleagues, like, okay, tell me, any child that's graduated from me, do you have a problem with the frontal S, or do you have a problem with that collided R? The answer is going to be no. And that's because I focused on building accurate motor plans and programs early on, realizing that the frontally lisped S and the glided R can become persistent through adulthood. Those are the two sounds in America and in English that we're concerned about, is that rounded R and that frontally lisped S. They can persist through adulthood despite years and years of speech therapy. Early on, at age 3, we are planting that seed to keep the teeth together for the S. We're planting the seed to have the hungry dog teeth when it comes to the R, to unround those lips. So we're working really early to plant those accurate motor plans and programs early on when it comes to the R and the S. But I'll tell you, even for myself, who takes it very seriously at an early age, it's so much more difficult if I start working on it at 5 years of age instead of 3. Now, number 9, low therapy intensity or irregular attendance. Like anything, consistency is the key to success. So it is very important that the child is frequently practicing the sounds. So I have a treatment target that I send home with the parents. It's either a sentence strip or a paragraph, or it's a complex sentence. And I say every single day, one time every single day, we want to habit stack this into your routine. So we want to tape this on the wall where your toothbrush is and say it when the child brushes their teeth when they're going to bed, one time every single day. Or at bedtime, we're going to have this on the bedstand and we're going to read it as part of the bedtime routine. It needs to be embedded into a routine that you religiously follow every single day. And we need to add that into the routine. And we only need to do it one time a day. So frequency trumps, how often trumps how much. So I don't want them to work on it 2 hours one day a week. Instead, I'd like them to work on it for a couple minutes every single day. Consistency is the key to success. So if you do not have, and I've had this many times where you have someone that's missing half of the therapy sessions, then it's going to be very difficult to make progress. Number 10, environmental barriers. This is when we're looking at there's just no way to see the child because, for instance, the child doesn't have transportation to regularly work. Maybe they're in a rural area, or maybe even what happens with many speech therapists is they're working and providing consultant services to large groups of children. These are factors that you don't have control over, unfortunately. These environmental barriers where people have caseloads of over 100 children, and you have one speech therapist, so they're consulting with a teacher who's also overwhelmed. This kind of situation is something that is going to be very difficult. So I am going to give you the 3 keys to success. And these keys to success now, they will help in overcoming these environmental barriers if you can hold tight to these 3 keys to success. The first key to success is the target. Now, I would attribute the target, based on all of the research we've done, roughly to 80% of your outcomes. See it as kind of like food. Like if you want to be healthy, what you ingest is really going to matter. No matter how much exercise, you can't exercise or out exercise a bad diet, right? It's the same way with speech therapy. Your target is like your food. If you don't have an optimal target, then even if you're doing all of the right strategies, even if you're very engaging and charismatic and you're doing dynamic temporal tactile cueing, you're doing everything right, you're getting a high density of productions, you're still not going to make the gains. It's the target. The higher you aim, the higher the gains. So that's why with every single child I work with, now when I say every single child, when I'm working with a child who's mentally speaking and just starting to develop speech, I'll even use this. I go right for the SW blends. If I'm working with a child who's a vowelizer, who's like, what do I go for? SW blends. Why the SW blends? Because in our research, what we found is S blends are more powerful than any other blends. We compared all of the blends in our summer program we do, and the S blends got the greatest gains. And this is why. This is what I attribute to. The S is a very complex sound. The S is also very importantly, if you produce the S, it produces a cup around the alveolar ridge, the bumpy ridge, all throughout the mouth. I mean, posteriorly, towards the front and back, all that rainbow, right? If you just produce the S with me right now as you're listening to this podcast, it's like this. You're going to feel it cup up like a suction cup all around the ridge, all around your mouth. So as a result, it is going to have this direct impact on multiple sounds that are located throughout the mouth. Okay, I always think of it as the Taylor Swift of the mouth, popular all around with all these different demographics all over the place. It's popular, right? So when we have this S blend, you're going to get greater gains on non-targeted sounds than the other blends. So for instance, the blend we found to be the weakest was the TH blend. So that's where you're sticking your tongue out. So for instance, if you're saying the word three. Now, when you're sticking your tongue out of your mouth, there's not a lot going on out there. Is the THR blend very complex? Yes, it's very complex. It's one of the most complex blends in our language. However, it's very difficult to produce as well. However, it's not popular. It's outside of the mouth. So there's no other sounds occurring out there. So you're not going to have that direct impact that you do with the S that is cupping all over through the mouth, and you have that complexity of the friction, the fricative airflow, where the airflow is seeping through in that nice tight suction. So it's a complex sound, but it's also like omnipresent all over the place, right? So I'm going to go for the S blends. But why not ST or SK or SP? And that's because why SW? That's because ST and SP and SK are two what we call in our field obstructed obstruent sounds. You can think of obstructed where the airflow is obstructed, right? So they're too similar. So you're going from like st and you stop it. It's obstructed airflow to an obstructed airflow sound. SP, sp, SK, sp. Okay, there you hear the obstruction as you're listening to the podcast. SW, you think of as a Cirque du Soleil in the mouth. This is going to be complex motor coordination because you're going from a friction airflow sound to a maximally distinct. So we're talking very different sound, which is the W, which is a glide, in which literally you have the mouth gliding from a ooh. Ah. So if you think about the wow, it is opposite in more ways than just the manner it's produced, in which the airflow is gliding. It's also your lips are rounded, where at the S, your lips are retracted. So it's very different than the S. So we have the manner in which the airflow is gliding. You have the placement of the W, and in the sense of the lips being opposite to what they are in the S. So it's very different in the tongues and an opposite airflow position, which is it's much lowered, and you have the airflow flowing out of that. So we're going from 0 to 100 and putting together in a blend form. It's very complex, very Cirque du Soleil in the mouth. So remember, challenge creates change. You want something cluster because it's complex, and not just any old cluster. You want a distinct cluster. You want a cluster that is maximally different from one another. So we're really doing that complex motor coordination for greater gains. So we have a complex cluster. That's going to be the most important factor, is the complexity of your cluster. The second factor, which goes with it, is that you're using dynamic, temporal, tactile cueing. What do I mean by that? You're going to use every single tool in your toolbox, because you're not going to ask if the child can produce SW blends. If you're asking that, you're going to say no. The child goes, they can produce SW blends. So I'm going to pick instead pa, the easiest sound, or ba, or da, or ta. When you do that, you're taking your chisel out and chiseling the rock. That's nothing, right? You want to take dynamite to that rock. So we want to say, I'm going to go for SW. And how am I going to do that? Now, this is where we visit Edythe Strand and her dynamic, temporal, tactile cueing. And that's where we go 0 miles an hour very, very slowly. We use choral speech with the child. We use every single cue in our toolbox to elicit accurate production with the child. We're carrying that child, right, to produce the SW blend. And then, of course, we're going to fade out the cues, always making sure we have an 80% accuracy level. Now, why is this dynamic? Because it's moment to moment. So 1 second, I could be giving 100% cueing with the child, going 0 miles a minute, 0 miles an hour. I'm sorry. So I'm doing the S with the child. And you can see that in video clips in my book, where we're working with child, where that person is holding that S for a very long time. And you're worried that clinician's going to pass out, but that's how long it takes for the child to join her, to hear the sound and join her. So you're going to see that S, and then we're going to go up to the ooh, and you're going to see that. And then maybe the child's got it, and the child's producing it. And maybe there's moments where later on in that session, you're not providing any cues at all, and the child's doing it all by themselves. And then the second later, you're going maximum cues again, because perhaps the child's losing their attention to the task, or they're lacking motivation, or they're getting tired. So it's very much moment to moment, like a dance, in which you're always ensuring that the child's 80% accurate. And your cueing can go up and down that maximum level to a minimal level to no level from a moment to moment basis, like a roller coaster ride, up and down and up and down and up and down. You're always responding with a different level of cueing depending on the child. You're very much all in. And that's why the magic occurs when you're totally present with the child. You're not And that's how the way she keeps data, Edythe Strand, is she'll just do a quick probe every couple of sessions, because you can't really be keeping data while you're doing this, because you have to be all in cueing the child and responsively on a moment-to-moment basis, changing your cues as necessary. Number one, as I mentioned before, you have a complex cluster. And I like to start right at the sentence level. And the reason I like to start at that sentence level is because speech is a continuous motor activity. It's not a discrete motor activity. And what we see again and again in the research is the further what you're doing is from speech. If you're working on sounds in isolation, the harder it is going to make generalizable gains. I don't think anyone speaks in sounds. I don't think anyone speaks in single words. So I always just go right into the sentences. The third factor that's going to matter if you want to overcome all of these negative predictive factors and you want to get great gains despite these predictive factors that are prognostic of poor outcomes. And that is going to be ensuring the 80% accuracy challenge point. So this is very important because practice makes permanent. And what a lot of times what people will do is they will say, okay, we're working at 80% accuracy. Okay, the child's below 80% accurate. So what am I going to do? Well, I'm going to practice more at this level. So let me give you an example. The child simply is not able to produce the F. It's a very complex movement. The F is, first you're going to curl the bottom lip over the bottom teeth. Then you're going to close the mouth. And then after closing the mouth, you're going to blow, right? Placing the teeth over the bottom lip, and then you're going to blow. It's a very complex 3-step process. And you're giving the child maximum cueing. And you're like, okay, we're going to do this F. And the child's just not there yet. They're not able to do it yet. And instead you're like, okay, but let's try it again, and let's try it again, and let's try it again. I know we all do this. And the child has misproduced it 9 times. The 10th time they have the F. So then that 10th time they get that reinforcement. So what are you reinforcing? So you're saying, okay, when I say a reinforcement, it's a natural activity. It's part of the natural reward activity. It's okay, well, here's the puppet for the brown bear puppet show that we're doing, right? You're the zoologist, you get to go put this in the zoo. Now, when we're talking about that, what have you just rewarded? You've rewarded 90% of the time the child is saying the P for the F. The child's saying poor. Now let's do it again. Let's do it again. Poor. Let's do it again. Let's do it. Poor. Okay, let's try this now. Poor. Let's do it. Poor. Okay, we got that now. Poor. Okay. So you're thinking about this and you're thinking, yay, I got the F sound. Whoop, 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 whoop. We're making progress. Are you making progress? Or are you simply reinforcing an errored pattern? So when you're in those situations, when you're giving them a maximum level of cueing, every cue that you have in your toolbox, and the child is still not able to produce the sound, a lot of times it's best to work on a neighboring sound instead. For instance, the child is stopping all of the continuous airflow sounds. Maybe work on the S and Z instead of the F and V, because F and V right now is still just a little bit too complex. But we're teaching them something different, which is to continue that airflow by working on a continuous airflow sound. We're going to get back to the FMV later. In the meantime, I'm going to be modeling FMV and showing them the F. Look at my teeth. And F is one of those sounds where I have just practiced chomping. Like, I see your vampire teeth. I see the vampire teeth. Because it is a very complex sound from any 3-year-old. So I just have vampire teeth. Oh, it's scary. Okay. And just getting them used to placing those teeth on top of their lip is something in itself. Okay. So those are going to be the 3 strategies in which you're going to be able to still make really substantial gains in working with children that present with these factors that are outside of your control. For instance, when it comes to the environmental barriers, I have had children where the attendance has not been optimal because it's been difficult for the parents to get them to speech therapy, but the parent has been practicing every single day with the sentence strip nonetheless. So even though outside of my control, they haven't been able to come to therapy, because the parent is using a complex target, because the parent is giving them the dynamic temporal tactile cueing so that they're able to do it correctly, and because the parent has been going 0 miles an hour and making sure that they're producing those sounds accurately, the parent has made sure, or it could be a paraprofessional, it could be a teacher, it could be someone that's not a speech pathologist. This child has made great gains. Now, it hasn't happened naturally. It's because they followed these 3 rules. So when we're looking at children, as I said before, with attentional difficulties, if you're following these 3 rules, you're still going to make substantial gains. Now, what you're going to tend to see is you're going to see it's going to be at a slower pace, but realize that you are creating system-wide change. So great things are happening. Don't feel bad if you're like, I've been at a sentence strip. I haven't moved to the paragraph, and I've been at a sentence strip all year. Well, that's fine. If you've been at a sentence strip all year and this child has been producing clusters accurately, S-blends accurately, these challenging sounds at a sentence level accurately all year, great things have been happening. You've been creating system-wide linguistic change in this child. And what you're going to see is maybe in the beginning, you're going to see the gains slowly occur, but you're going to see great things happen. It's just going to take a little bit longer. I encourage you, don't ask, can the child produce this sound? Don't pick your targets based on, okay, this is a speech sound disorder test. These are the sounds I got incorrect. What is going to be the earliest developing sound that I'm going to work on? I'll work on that sound. No. Pick the SW cluster. Pick an S-blend. Don't pick an S-blend that's a simple S-blend stop, but that's an S-blend glide or an S-liquid, such as slide. We're going to want to do that instead. And when you do that, Cirque du Soleil in the mouth, that target, think about the target. I'm going to tell you the target matters so much, I give it an 80%. 80% of your outcomes is going to be based on that target. Think about that target. So you have the child producing that target. It could be the same target they're producing all year. Good things are happening. You have a complex target they're producing all year. It's right at their challenge point. It's at an 80% accuracy level. It's not too easy for them, in which they're at a 90% accuracy level. They're not being challenged. They're just plateauing. It's not too hard for them, in which they're practicing irred speech, in which 90% of the time they're producing it incorrectly. And then you're giving them a natural reward for it. It's just, what are you doing? Are you making it worse? I don't know. We need to think about that. Or it's frustrating for the child because they never get it right and you're asking them to do it. We have to be at that 80% sweet spot at all times. And how are we going to do that? We're not going to ask if the child can do it. We're going to say, how can the child do it at 80%? And that's why you need to have that toolbox with all of your cues, and it needs to be open. So you need to be ready to put the tools in. You need to be ready to take the tools out on a second's notice. And that means you need to be present. This is why I like my SIS membership so much, is that the activities are all set up. They're already there. They're already educationally rich. They already treat the whole child. It's all ready. I'm not reaching around looking for toys and looking for activities. I've got the good stuff all ready to go. I'm all in with the child. It's kind of like I have this picnic basket and it's full of like organic, healthy food, all prepared and ready to go, right? I can just enjoy the person's company. I get the good stuff right here. That's how I feel about that. That's why it's nice to have an educationally rich activity that's highly engaging. It's already right there. So you can focus on these 3 areas. Focus on that target, focus on that 80%, and focus on the cueing from a second to second, moment to moment basis. That's what you're going to do. And if you're doing that, great things are going to happen. So I want you to do what you do best, roll up your sleeves, and make the world a better place, one child at a time. You are always going to be first.